Welcome to the Deep Dive. We're here to, well, cut through the noise and give you a shortcut. A way to get truly well-informed about nursing aspects that go way beyond just the clinical stuff. You know, the human element, the social fabric, how all that impacts health. Today, we're diving deep into the intricate world of social, ethical, and legal issues, specifically for childbearing families. For you, whether you're studying nursing or just deeply curious, this isn't just theory. It's the real human complexities you will face. These are the nuances shaping every patient interaction. It's foundational knowledge for, truly holistic care.
Exactly. Our mission here is to pull out the most vital nuggets of insight from our source materials, articles, research, notes. We want to give you those aha moments, the things that connect the dots and really prepare you for patient-centered care, seeing the whole person, right? Not just a diagnosis.
Okay, let's unpack this then. When we think about care, the family unit seems so basic, so foundational. But what does family really mean in nursing today? Because the old picture is not always what you walk into.
That's a really crucial starting point. The sources stress that family as the social institution is fundamental. But what is a family now? It's so diverse, we're not just talking traditional nuclear families anymore. You'll see extended families, single-parent households, blended families, adoptive families, same-sex parent families. And each structure, it brings its own dynamics, its own strengths, and, potential challenges that absolutely impact health and how you plan care. And maybe even more insightful is understanding what makes a family functional. Think about it. Functional families, they can communicate openly, they're flexible, they support each other, they generally agree on parenting roles, they solve problems together, show resilience, they adapt, they manage stress and crisis. When those things are strong, the family's better equipped to support, say, a new mother and baby.
Right.
But conversely, things like chronic illness or substance abuse, serious mental health issues, those can deeply interfere with that functioning. So as a nurse, recognizing these characteristics helps you assess a family's capacity, where they might need more support, more resources. It's looking beyond just the patient.
To their whole support system.
Oh,
Okay.
yeah.
So we've broadened family. Let's pivot to culture. That's another huge layer, isn't it? How do cultural values and beliefs shape something as, universal as birth?
Yeah.
Often in ways we might not expect.
Oh, absolutely. Culture is basically the shared values, beliefs, traditions, practices of a group. And within that, you have ethnicity, which is that group's identity based on shared characteristics, physical and cultural. Now, ethnocentrism, believing your own culture's way is best, that's something nurses have to actively fight against. The real aha here is transcultural nursing, providing care that's not just respectful, but actually fits the patient's cultural needs and values, meeting them where they are.
Culturally speaking.
Yes, and the sources. They give some really vivid examples of how culture shows up in health beliefs. For instance, the belief in hot and cold conditions. It's common in many cultures, and it dictates what foods or activities are okay during pregnancy or postpartum, or the Chinese idea of yin and yang, that balance in life. Then there's the evil eye, a belief that envy can cause illness. So some families might be hesitant to, show off their newborn. And you might see traditional healing practices, things like cupping, moxibustion, coining, gua sha methods using pressure or heat.
Okay.
Or specific herbs. Ginseng for general health, maybe ginger for nausea, aloe for skin. You might also hear about red cohosh or black cohosh, sometimes used around labor or for menopausal symptoms. The crucial thing for nurses isn't necessarily to endorse these medically, but to acknowledge them. They're deeply held practices.
Ignoring them could break trust.
Exactly. Acknowledging them builds rapport. It shows respect.
That's fascinating. And it makes me think, how does this cultural stuff play out in basic communication? Yeah. In the clinic, at the bedside, because I imagine that's where misunderstandings can really, really derail things.
Oh, absolutely. Communication styles vary hugely. Misunderstandings create huge barriers, affects everything from patient teaching to getting proper consent, like silence, what does it mean? Or a nod, a smile. Totally different meanings across cultures. Eye contact is a big one. In many Western cultures, direct eye contact means honesty, right?
Yeah.
But in some Native American, Middle Eastern, Hispanic, Latina, Mexican cultures, avoiding direct eye contact can actually be a sign of respect, deference.
Didn't know that specifically.
And touch. Nurses often use touch to show empathy, but it might be culturally sensitive. For instance, in some Hispanic cultures, it might feel inappropriate unless the patient initiates it.
Okay, so this leads right into language barriers then, which must be a huge issue in pregnancy care.
Critical. And there's a specific nursing care plan for this in our sources. Assessment starts with identifying the primary language, figuring out if an interpreter is needed. The patient problem is clear. Ineffective communication due to language barriers. That can lead to poor understanding of their condition, meds, instructions, everything.
So what are the goals?
Planned outcomes involve making sure a certified interpreter is used, setting up clear communication times, making sure basic needs are met, and the interventions. Crucially, always use a certified medical interpreter, never family members. That protects accuracy and patient privacy.
That's a key point. No family members.
Absolutely. And you need to speak clearly, slowly, respect cultural norms, give them time to respond, avoid jargon, obviously, and document everything meticulously, all communication. The goal is mutual understanding, building trust. That's foundational for safe care, especially with sensitive topics like prenatal plans or medication use.
It's so clear cultural competence isn't optional. But okay, beyond culture, what about the wider societal forces? Like, how does economic status create totally different realities for childbearing families, even if they share a culture?
That's the next really complex layer, and it profoundly impacts access and health outcomes. The sources talk about the socioeconomic status continuum. It ranges from affluent, with lots of resources, down through middle class, working poor unemployed, and then the new poor people facing sudden hardship.
Right.
Each level deeply affects a family's ability to get care, their financial stability, even their time orientation.
Time orientation, what do you mean?
Like, can they afford time off work for early, consistent prenatal appointments? Or are they forced to wait until late in the pregnancy because of money or logistics? That delay means potentially missed diagnoses, missed chances for vital preventative care.
And when I read about homelessness and maternal health, that really hit me. It's such a profound, often hidden challenge.
It is. Homelessness is a massive factor for maternal newborn outcomes. It creates this cascade of health problems. The sources highlight links to shame, despair, violence, substance abuse, mental health issues, all contributing to poor nutrition and critically inconsistent prenatal care. Imagine managing pregnancy without a stable home, reliable food, a safe place.
It's hard to fathom.
And it leads to higher rates of low birth weight, preterm birth, other bad outcomes. This ties right into the broader disparities in healthcare. Our sources list many factors for poor access: poverty, unemployment, no insurance, being an adolescent, being in a minority group, living in the inner city or rural areas, being unmarried, less than a high school education, not speaking English. These aren't just individual issues, they're systemic barriers creating huge inequities.
So the practical barriers to just getting prenatal care.
Often boils down to money. No insurance, maybe not enough female providers, cultural factors that deter seeking care, institutional barriers like long waits, lack of transport, no childcare. As nurses, our job often includes helping patients navigate this maze, connect them to resources.
Are there systems in place to help?
Yes, thankfully. Knowing about them is key for nurses. Public programs like Medicare, Medicaid, CHIP, the Children's Health Insurance Program are vital for coverage. There's also TANF, Temporary Assistance for Needy Families for financial aid, and specific services for shelter and health care for the homeless.
So connecting this to the bigger picture, how does a nurse advocate beyond just bedside care? What's the active role in tackling these disparities?
It's really about shifting from just a care versus cure mindset to something more holistic, more proactive. As nurses, our role goes deep into advocacy, understanding resource allocation, focusing on population health. It means not just treating the person in front of you, but seeing the broader social determinants affecting their health and actively working to reduce those gaps.
Being part of the systemic solution.
Exactly. Making sure patients get the resources they need, recognizing that sometimes the best intervention isn't a pill, it's a referral to a social worker or a food bank.
That really paints a broad picture of nursing. Okay, let's transition now to two incredibly critical, often hidden dangers: intimate partner violence and human trafficking. These are areas where a nurse's observation, their direct, compassionate intervention, it can literally save a life.
Profoundly serious issues, yes. Intimate partner violence, IPV, it's comprehensive. Physical sexual abuse, but also emotional, economic, psychological abuse, stalking. Our sources note it's more common in economically disadvantaged groups, which again shows how social factors play into even something this personal. And to really grasp IPV, you have to understand the cycle of violence. It's not random, it's this insidious, predictable pattern.
Yeah, what does that look like?
It starts with tension building. Minor incidents, more arguments. Maybe the abuser increases alcohol or drug use. An atmosphere of fear builds. Then the battering incident, an explosion of violence, often causing significant physical injury, needing medical help. And then, strangely, the honeymoon phase. The abuser becomes loving, promises change, might give gifts.
Ah, so that's what makes it hard to leave.
Precisely. That temporary hope traps the victim. The cycle repeats, tragically. Nurses need to recognize this cycle, almost like the pathophysiology of a disease.
So what's the nurse's role? How do you intervene?
The nurse's role in prevention of abuse starts with sharp assessment, compassionate intervention, looking for red flags, and asking direct, non-judgmental questions in private. Things like, are you afraid of anyone at home? Or has anyone ever forced you to have sexual activities?
Direct questions.
Yes, ensuring they feel safe to disclose. Also, identifying characteristics of abusers helps. Often dominance, control, intense jealousy, low self-esteem, poor impulse control. Understanding that dynamic is key for safety planning. And it's so important to debunk the myths and realities about violence against women. Like the myth that battered women syndrome is just a lower socioeconomic problem. No, violence against women is a major cause of injury across all groups.
Right.
Or the myth that the abuser is out of control. Actually, abusers often maintain control, choosing their actions strategically. Knowing the myths helps nurses provide unbiased, effective care. No victim blaming.
Equally vital, and maybe even harder to spot, is human trafficking, a crime hiding in plain sight. The nurse's role seems critical here.
Absolutely critical. Human trafficking involves recruitment, movement, harboring of people for sexual exploitation or forced labor. It's a global and national crisis. Victims are often isolated, severely exploited, and might show up in healthcare for completely unrelated reasons.
So what are the signs, the red flags?
Nurses need to know these human trafficking red flags. These are the signs and symptoms. Things like isolation from family or friends, reluctance to speak, maybe someone else speaks for them. Obvious physical or mental abuse signs, being unusually submissive, fear of authority figures, having no ID or money.
Okay.
Inconsistent stories about injuries or how they got there, maybe being foreign, speaking English, but having a handler controlling the conversation. Signs of homelessness, branding or tattoos, identifying them as property, having luxury items they couldn't afford. Or, especially in minors, a high number of sex partners for their age.
Wow. That's a lot to look for.
It is. These are critical indicators. They demand immediate, careful attention and intervention from a nurse. The Mandy case study in our sources is a good example of applying the nursing process here. Mandy might come in with unexplained injuries, seem withdrawn, or be very submissive when her partner's there. Your assessment goes beyond just the physical injury. You probe the social situation carefully. Problem identification might be risk for injury or powerlessness.
And the intervention.
Planned interventions focus on ensuring safety, providing resources discreetly, maybe initiating referrals to social services or law enforcement, while documenting everything meticulously. Identifying the flags is step one in potentially life-saving care.
It's clear nurses are often on the absolute front lines. Which brings up a big question. How do nurses use ethical principles in these really tough situations?
Wow.
And what are the legal guardrails?
That's exactly where our ethical and legal compass guides us. Every decision. We use ethical theories like deontology, duty-based ethics, or utilitarianism, greatest good for the greatest number, and human rights model. But the core ethical principles are what we apply daily. Autonomy, the patient's right to choose for themselves. Self-determination, beneficence, our duty to do good, act in their best interest. Non-maleficence, first, do no harm, avoid causing injury. Justice, fairness, treating everyone equitably, allocating resources fairly, fidelity, keeping promises, maintaining trust, truth, veracity, telling the truth, being honest with patients, accountability, taking responsibility for our actions, and underpinning all of this, confidentiality, protecting patient information, strictly following rules like HIPAA, vital for trust and privacy.
Okay, let's apply those. What about specific complex reproductive issues, the ones that often stir public debate? How does a nurse navigate those?
Right. Take elective pregnancy termination, abortion. The legal landscape is, well, shifting dramatically in many places, but the ethical and social debates, they continue. As nurses, our role is impartial, non-judgmental care, provide accurate info, support the patient, whatever our personal beliefs, focus on their well-being and autonomy.
What about mandated contraception?
That raises tough ethical issues. Requiring contraception, say, for someone with substance abuse issues, it pits autonomy against public health concerns, individual rights versus societal protection. The sources mention different methods here: hormone injections, IUDs, barrier methods. Each needs careful patient education and respect for choice.
Hmm.
Then there's fetal injury, when maternal actions might harm the fetus. Huge dilemma. Maternal rights versus fetal well-being. Infertility treatment, high cost, huge emotional burden. Ethical questions about access, genetics, the use of medications for infertility, and surrogate parenting. Very complex, ethically and legally. Genetic ties, parental rights, well-being of everyone involved, surrogate parents, child.
So beyond ethics, there's the legal side. What are the key legal concepts nurses absolutely must know to protect everyone involved?
The legal framework is crucial for safety and accountability. First, privacy issues. HIPAA is the absolute bedrock for protecting patient health information. Compliance is non-negotiable. Breaches have serious consequences.
Okay, and malpractice, that's always a concern.
Always. To prove malpractice, you need four things. 1, a duty existed, professional relationship. 2, a breach of duty occurred, failed standard of care. 3, an injury happened to the patient. 4, proximate cause. The breach directly caused the injury. Common claims in maternity. Things like perinatal injury, mismanaging prolonged labor, uterine rupture.
So how do you prevent that?
Best prevention. Meticulous documentation. Keeping your expertise up to date. Always staying within your scope of practice. And then, critically, informed consent. A patient's absolute right to accept or refuse care after full disclosure. Risks, benefits, alternatives. And it must be voluntary consent, freely given, no coercion. It's not just a signature, it's an ongoing conversation ensuring understanding and agreement about everything: care, plans, meds, procedures.
So it sounds like ethical decision-making is a process, like the nursing process.
Exactly. Assess the dilemma, analyze the options, plan interventions, upholding principles, implement, evaluate. It ensures that even when things get really complex, patient advocacy, respecting their voice and choices, remains absolutely central, even with difficult or controversial choices.
Okay, one last practical area: early discharge. Hospital stays are getting shorter. How do nurses handle that?
Good point. With early discharge and shorter stays, our role extends beyond the hospital walls. We need strategies like post-discharge phone calls, maybe early home visits, follow-up calls, to ensure ongoing support and monitoring for mom and baby. And clear, comprehensive discharge teaching is absolutely essential, covering everything: newborn care, recognizing complications, medication schedules, empowering families for safe care at home. It's not just nice to do, it's critical for preventing readmissions and ensuring good outcomes.
Wow. Okay, that was a truly essential deep dive. We've covered, well, an incredible amount. From understanding diverse families and cultural beliefs to tackling huge social issues like homelessness, IPV, human trafficking, and navigating those complex ethical and legal tightropes that nurses walk every single day. It really paints a much richer, more complex picture of nursing than just clinical skills.
It absolutely does. It really highlights that nursing isn't just about clinical know-how or giving meds. It's deeply rooted in understanding the patient's whole social world, their unique cultural values, their fundamental legal rights. These insights, these nuggets, they aren't just academic points. They are essential for providing truly competent, compassionate, safe care, care that respects dignity, especially during the vulnerable childbearing time. They help you see the full picture, not just the symptoms on the chart.
So the final thought for you, our listener: as you move forward in your nursing journey, how will you make sure every patient's unique story, their social reality, their culture, their rights, truly informs your care, not just their medical chart? That's the real challenge, isn't it? And maybe the true mark of a holistic nurse. Something to think about.